Welcome to the deep dive. Today we're really getting into a set of revision notes, specifically focusing on delirium tremens.
That's right. Think of these notes as, well, kind of a roadmap for understanding DT, everything from the basics right through to clinical management.
And our goal here, our mission for this deep dive, is to unpack all that information for you. We want to pull out the really crucial high-yield bits and, structure it so it actually sticks in your head.
Exactly. This session is built directly from those notes you shared, tailored to help you get a really solid handle on DT for your revision.
Okay, let's dive in then. Let's unpack this. What exactly is delirium tremens at its most fundamental level?
Okay, so at its core, delirium tremens, or DT, is a severe form of alcohol withdrawal syndrome. And severe is definitely the word to emphasize.
Right, so it's way beyond just having the shakes or feeling a bit anxious after stopping drinking. What makes it severe, according to these notes?
Well, the notes really point to three key things. First, a rapid onset of altered mental status. So we're talking significant confusion, disorientation.
Okay, altered mind.
Second, major autonomic hyperactivity. That means the body's involuntary systems are going haywire, heart rate, blood pressure, sweating.
Body in chaos.
And third, perceptual disturbances. Things like seeing or hearing things that aren't really there. Hallucinations.
Got it. Altered mind, body chaos, distorted reality. And who typically gets this?
It tends to emerge in people who've been drinking heavily and for a prolonged period when they suddenly stop or drastically cut down their intake.
And the notes are pretty clear about how serious this is.
Oh, absolutely. They explicitly state it's a medical emergency. It has a very real potential to be life-threatening.
That's vital to remember. How common is it actually? What do the notes say?
In the general population, thankfully, it's pretty rare, less than 1%. But among patients who are actually alcohol dependent, the number jumps up closer to 2%.
And historically, before we had effective treatments, the outlook was much worse.
Much worse. The notes mention mortality rates historically running as high as 37% if it wasn't treated properly. That figure alone really tells you how dangerous DT is.
Yeah, it really highlights the importance of modern management. As a quick memory aid, the name itself, delirium tremens. Delirium obviously points to that confusion, the altered mental state.
Right.
And tremens, that could make you think of the physical tremors, but maybe also the tremendous danger historically if left untreated.
That's actually a pretty good way to link the name to the core features and its serious nature.
Okay, so that covers the what. Now let's shift to the why. What actually triggers DT based on this material?
So the main trigger is that abrupt stop or significant reduction in drinking after a long period of heavy use. The notes explain it involves something called neuroadaptation.
Neuroadaptation. So the brain actually changes its baseline because alcohol is always there.
Precisely. The brain adapts to the constant presence of alcohol, which acts as a depressant, kind of boosting the inhibitory signals. When you suddenly take that alcohol away, you get this dramatic neurochemical swing.
Oh, okay.
The notes say it leads to a drop in those calming inhibitory neurotransmitters and a big surge in excitatory activity.
So it's like alcohol's been holding down the brake pedal, and withdrawal is suddenly lifting the foot off the brake and slamming down the accelerator.
That's a really good analogy, actually. The brain's activity just skyrockets. The notes specifically mention an increase in glutamate playing a key role in this excitatory surge. They also point out that other factors like, genetics, underlying neurochemistry, and even environmental stuff can contribute. It's complex.
Understanding that imbalance, less inhibition, more excitation seems key to understanding why all those symptoms happen.
It absolutely is. That's the fundamental pathophysiology.
Okay, now this is where it gets really practical for assessment. Figuring out who is most at risk. The notes give a pretty clear list of risk factors.
Yes, they do. Straight from the source material, the big ones are a history of heavy and chronic alcohol use itself, obviously.
Makes sense.
Having had previous episodes of alcohol withdrawal, being older. Having other medical problems and liver disease is specifically called out here.
Right, liver disease keeps popping up.
And genetic factors can play a role too.
So those are the main flags. But the notes add a few more things that increase the risk.
Yeah, there are some others, like having a specific history of DT itself or alcohol withdrawal seizures in the past.
Right.
Also, recent, really excessive drinking, even if they haven't completely stopped, abnormal liver function tests reinforcing that liver link again, and showing signs of severe withdrawal before the full DT picture develops.
It's quite a checklist. For revision, maybe grouping these might help. Like you've got the alcohol history factors, past withdrawal severity factors, and then other medical vulnerabilities.
Absolutely. Grouping or visualizing them somehow is a great strategy for remembering that list.
So we've talked about the why, the neurochemical chaos. Let's connect that right back to the what, the pathophysiology. How does that imbalance actually cause the symptoms of DT?
Well, like we said, chronic alcohol use messes up the balance between the brain's go and stop signals, the excitatory and inhibitory neurotransmitters.
Right.
The direct result is the central nervous system becomes basically hyperactive. It's just firing way too much.
Just a lot of control.
Exactly. So when the alcohol is suddenly removed, that break the inhibition from things like GABA is lifted, and the accelerator, the excitation, driven partly by that glutamate increase, takes over.
Ah, okay.
And that CNS overactivity is what directly causes the symptoms we listed. The agitation, confusion, hallucinations, the racing heart, sweating, all of it.
That image of the brain going into overdrive when the alcohol brake is off and the accelerator is floored,
Yeah.
that really helps visualize the mechanism.
It does capture the core idea pretty well.
Okay, let's switch gears to clinical practice. Someone presents with these symptoms confused, agitated, physically unstable. It's vital to think, what else could this be? What does the source material say about the differential diagnosis?
Yeah, this is absolutely crucial. You have to rule out other things. The notes list several important categories. First, general medical problems, like infections or significant metabolic disturbances.
So standard medical workup is essential.
Definitely. Also, side effects from other medications could look similar. And critically, withdrawal from other substances needs to be considered.
Huh, like what?
The notes specifically mention benzodiazepines, opioids, or other sedative hypnotics. Things that also calm the brain down can cause a rebound excitation when stopped.
Makes total sense. What else?
Beyond substances, the notes say to consider psychiatric disorders. They specifically flag bipolar disorder and schizophrenia.
Okay.
And finally, various neurological conditions are on the list too, things like dementia, stroke, or even encephalitis, an infection of the brain itself.
That's a broad list. Grouping them seems smart for revision, like you said.
Yeah.
Medical issues, other drug issues, psychiatric conditions, and then brain structure or function problems.
Yeah, that's a very helpful way to organize the differentials mentally.
Let's zoom out again and look at the bigger picture, epidemiology. What do these notes tell us about how often DT actually occurs?
They give some useful context, especially for the UK. The estimate is that somewhere between 5 to 10% of all alcohol withdrawal cases might progress to full-blown delirium tremens.
And it's more common in those heavy chronic users we talked about.
Yes, definitely higher incidence there, linking back to the risk factors.
What about the overall rates of alcohol problems?
The source gives some background numbers. Alcohol use disorder is seen in about 20% to 36% of patients in primary care. In England specifically, alcohol dependence affects around 4% of 16 to 65-year-olds.
That's quite a few people.
It is. And there's a gender difference noted. 6% of men versus 2% of women in that age group. Now, digging deeper into those who are dependent, the notes say if their withdrawal isn't treated, about 6% develop withdrawal symptoms. And then, of those people having symptoms, up to 10% might go on to develop DT.
Okay, so it's a fraction of a fraction, but a very serious one.
Exactly. And it also mentions that about a third of people with significant withdrawal might have an alcohol withdrawal seizure, which is another serious complication.
Let's try that calculation exercise mentioned in the notes, just to make it concrete.
Yeah.
If you had, say, 100 alcohol-dependent patients in England, aged 16, 65, who went into untreated withdrawal, how many might get DT based on those stats?
Right, let's walk through it. If 6% get withdrawal symptoms, that's 6 out of 100. Then, if up to 10% of those 6 get DT, well, 10% of 6 is 0.6. So statistically, less than 1 person in that group of 100 might develop DT from untreated withdrawal.
Wow. So it really underscores that while dependence is relatively common, DT is the severe, less frequent endpoint of withdrawal for a subset of those people.
Precisely. It's the extreme end.
Okay, let's get back to the bedside. What does a patient with DT actually look like? What are the key clinical features described in the notes?
They give a pretty detailed picture. For altered mental status, you're seeing profound confusion, disorientation, difficulty paying attention, the core delirium,
Right.
then the autonomic hyperactivity, really noticeable sweating, a fast heart rate tachycardia, high blood pressure hypertension, and often a fever.
The body system's clearly out of whack.
Definitely. And those perceptual disturbances we mentioned, visual or auditory hallucinations are common, sometimes delusions too.
What else?
Other things you'll likely see are tremors, restlessness, significant agitation and irritability, major problems sleeping, and sometimes nausea or vomiting. And in the really severe cases, seizures can happen too.
And when does this usually kick in after they stop drinking?
The notes typically point to an onset between 24 and 72 hours after cutting back or stopping alcohol, so
Yeah.
usually day 2 or 3.
What might you find on a physical exam apart from those specific DT symptoms?
Well, you might see signs pointing towards chronic alcohol use itself, or signs of underlying liver disease. The notes also specifically list things like rapid breathing, tachypnea, the tremor, dilated pupils, mydriasis, poor coordination, ataxia, the altered mental state, obviously, and in really critical situations, even cardiovascular collapse.
The notes also briefly mention the DSM-5 criteria.
Yeah, they touch on it. Criterion A is about stopping or reducing heavy, prolonged use. Criterion B lists those key symptoms we've been discussing, the autonomic signs, tremor, insomnia, nausea, vomiting, hallucination solutions, agitation, anxiety, and seizures. Then C and D just say it causes significant problems and isn't due to something else.
That list is helpful. Again, for remembering, grouping seems useful. Maybe mental symptoms, physical autonomic symptoms, and behavioral changes.
Yeah, thinking about it in those clusters, mind, body, behavior definitely helps organize that list of features.
Okay, so you suspect DT based on this picture. What investigations do the notes say are needed?
Well, the absolute first thing is always the clinical assessment. You need a thorough history, a good physical exam, and you really need to dig into their alcohol use and withdrawal symptoms. That's step 1.
Clinician's judgment first. Then what about tests?
Labs are vital. Blood tests to check liver function.
So that directly answers the question about why imaging might be needed. It's to exclude those other serious neurological mimics.
Puts it right in context.
All right, so DT is identified. How do we manage it? What's the core approach based on these revision notes?
The approach is really twofold. Good supportive care and specific medications. Supportive care means things like making sure the environment is safe and calm, keeping the patient hydrated, ensuring they get nutrition, and correcting any electrolyte imbalances.
Just managing the basics while the body is going through this.
Pretty much. And then medications are absolutely key. The notes are very clear. Benzodiazepines are the mainstay of treatment.
Why benzos?
Because they work on that GABA system, the brain's main inhibitory system, they essentially help put the brakes back on that overactive CNS.
Counteracting the withdrawal effect.
Exactly. The notes mention 2 ways of dosing them. Symptom-triggered, where you give meds based on how severe the withdrawal symptoms are using a scale, or a fixed-dose taper, where the dose is gradually reduced over time.
And it's not just about meds, right?
No, the notes emphasize a multidisciplinary approach is best involving addiction specialists, maybe psychiatrists, and experienced nurses. And because it's so serious, hospitalization is usually needed, especially if symptoms are severe, there are complications, or safety is a concern.
What if the standard benzo treatment isn't enough? The notes mentioned refractory cases.
Right. For those tough cases where benzos aren't fully controlling the symptoms, the notes outline stepping up treatment. This could mean using other sedating agents like phenobarbital, propofol, or dexmedetomidine.
The stronger stuff.
Yes. And a really crucial point they make is to actively look for and treat coexisting Wernicke's encephalopathy, that's the thiamine deficiency, often using high-dose IVB vitamins like Pabernex.
Addressing the nutritional side is critical, too.
Absolutely. And if things are still really difficult, the notes mention considering intensive care or getting anesthetics involved for deeper sedation.
Okay. And what about monitoring and follow-up?
Continuous monitoring is essential until they're stable. The notes mention using tools like the CIWA-R scale to track symptoms and guide treatment adjustments. Checking blood sugar and vital signs frequently is also standard.
And after they get through the acute phase?
Follow-up is vital. Referrals are key to community addiction services, maybe groups like AA, therapy like CBT, and psychiatric assessment to manage underlying depression or anxiety and support ongoing abstinence.
Okay, for management, I'm thinking that SBM idea helps. S for supportive care, B for benzodiazepines and the backup options for refractory cases, and M for monitoring and multidisciplinary follow-up.
SBM. Yeah, that's a neat way to capture the core management strategy from the notes.
Lastly, what's the prognosis? What's the likely outcome for someone with DT, And what are the potential bumps in the road, the complications?
The prognosis, the notes say, really depends on how severe it is, any other health problems the person has, and this is key how quickly treatment is started.
But generally with modern treatment, the outlook is much better than it used to be.
Oh, definitely. The notes state that most people, with the right treatment and support, recover within several days, up to about a week.
That huge drop from the old 37% mortality rate is really down to recognizing and treating it promptly.
It really is. But even with better survival, complications can still happen during the acute illness. Things like aspiration pneumonia, cardiovascular problems due to that autonomic instability, seizures, or injuries from falls or agitation.
And the specific mortality rate now.
The notes cite a figure of less than 5% mortality with early recognition and treatment. Still a serious condition, but a vast improvement.
Okay, so we've done a pretty deep dive through these revision notes on delirium tremens. We've covered the definition, that severe withdrawal state, the why behind it with the neurochemistry, who's most at risk, what it actually looks like, how to investigate it, and crucially, the management supportive care, benzos, escalating if needed, plus the outcomes and risks.
Yeah, we've tried to synthesize all that key information from the notes for you, structuring it logically to hopefully make it stick for revision.
So what's the big takeaway here? I think these notes really hammer home that even though treatments have improved survival dramatically, DT is still a major medical emergency. It's a really stark example of how chronic substance use can fundamentally change brain function with severe withdrawal consequences.
Absolutely. It demands fast recognition and aggressive, well-managed treatment. Which kind of raises a final thought, doesn't it?
What's that?
Well, even with these effective protocols and much better outcomes than in the past, what are the ongoing challenges in actually identifying everyone who's at high risk early enough in their withdrawal? Before they even get to the point of full DT and its potential complications, how do we catch them sooner?
That's a really important question to think about as you continue your learning. Hopefully this deep dive into the notes has been useful for your revision.
And for more deep dives and revision materials to help you prepare, don't forget to check out PassThemSRA.com and FreeMSRA.com.